All right, we are live. Maybe I'll give it a sec to see if someone joins. All right, so it's an honor and a pleasure to be a part of this year's CHW Unity Conference. Hello to everyone. We want to use our chat feature. Make sure we use our chat feature. Introduce yourself, say hello. My name is Dorel Clayton, and I work with Transitions Clinic Network. And I'm going to go ahead and share my screen for our presentation. Let's see. All right. So again, Transitions Clinic Network, we call it TCN for short. And I am the community health worker trainer with TCN. We're based out of San Francisco, San Francisco, California. And we have implemented this model across the nation, hiring community health workers with lived experience of incarceration to help those returning from incarceration to connect to healthcare and other means of well-being. I'm sorry. I am the presenter again, and I'm going to do an overview. I'm sorry. And I have a couple of co-hosts, Alicia Ashorn, as well as Tommy Green, and they'll introduce themselves when they speak. Unfortunately, Monya Harris fell ill, and so we want to send her positive energy and prayers in hopes that she feels better. So I'm going to give an overview. Our outline of this presentation is I will be giving an overview of the TCN model. So those that don't know about TCN can understand how we uniquely do community health work. And then my colleagues will then talk about being part of a primary care team and working in a clinic. We'll also collectively talk about outreach and engagement. And finally, we will talk about in-reach, going inside of the jails and prisons or the carceral system. So Transitions Clinic Network was created by Dr. Shira Shavit and Emily Wang, two providers who noticed the primary care for those returning from incarceration was very limited. And the way that it was done was very limited. And we now support 50 primary care programs in 14 states, including Puerto Rico. In California, we have 20 health systems in 12 counties. So California is where we have the most sites, with North Carolina being a close second. But again, we've supported programs in 14 different states, and we also have a site in Puerto Rico. When patients are incarcerated, we all know about mass incarceration. Well, folks who are incarcerated are growing older while in prison, and they have a lot of chronic health needs that don't really get met in the carceral system. Healthcare inside the carceral system is like none other when it comes to neglect, especially with chronic conditions. This is a photo of a therapy session. Carceral environments exacerbate poor health. This does not look very therapeutic, but again, this is a therapy session inside of San Quentin prison. Incarcerated people are dehumanized, living in conditions that are very unhealthy. On this photo, you can see they have fans, there's no air conditioning, and you're in a small space, so disease and germs will travel. In order to get help, to receive medical health care inside, you have to put in what's called a sick call. You fill out a paper to be seen by a provider. And whether or not you're seen based on how you articulate your symptoms, you might be seen and you might not. The other thing about that is they actually charge for it. A lot of people inside of prisons and jails don't have money, and it comes out of your trust fund. So if you're working one of the jobs is 40 cents a day or $1 a day, you might have to decide whether you're going to pay for that sick call or pay for cosmetics and toiletries and food, items from the commissary so that you can live. That's a choice that a lot of people have to make, and ultimately sometimes their health goes untreated because they chose to have those basic necessities. On contrary to what most people think, 80 to 85% of people sentenced to incarceration actually come home. But when they come home, not only do they have their belongings, they also have those chronic conditions that I was talking about. And they don't receive health care. A lot of people are uninsured. There was a release, those released from prison, there was an article done, the New England Journal of Medicine, that says that folks returning from incarceration are 12 times increased risk of death in the first 2 weeks after release. The leading causes of death are drug overdose, cardiovascular disease, homicide, suicide, and cancer. I'm sorry. Also, engagement strategies for justice-involved communities. Now, I told you about those two providers who started this model. Well, they asked the community. So this is what the feedback was from the community about engagement strategies for justice-involved communities. Include the individuals and the communities impacted by the criminal legal system in the design, implementation, and evaluation of programs. They know what they need, right? So rather than create programs without including them or having any input, we found that this was very valuable with the feedback. Also, incorporate a broad definition of health and well-being that looks different for different communities, looks different for different individuals. And so we want to have a broad definition of health and well-being. Also, adapt systems to be patient-centered, respecting a person's autonomy and their right to have their health care be the way they envision it. Also, empower patients, favor reintegration. We want to support reintegration back into the community with positive things and positive outlets, and also avoid replication of carceral systems. So a lot of times within the carceral system, you're told what you're going to do. You're told how things are going to go. We want to avoid that. We want to respect autonomy. We want folks to be at the forefront of their healthcare versus repeating or replicating those carceral systems that they're returning from. This photo is one that I love because what it shows is the difference between getting healthcare in the carceral system versus on the outside in the community with a community health worker. You can see on the left, the same gentleman that was receiving breathing treatments. And then you can see him also with a community health worker and someone showing empathy while also attending the appointment along with him to explain what's going on, explain his options, and to provide resources. Part of our core components as community health workers is to do in-reach into the carceral systems. And Tommy's going to talk about that in a little bit, a little more in depth, going inside and actually starting the process of connecting the resources, insurance, Medicaid, Medi-Cal before the person is released, community outreach. Being a cultural interpreter is very important as well. Coming from different communities, different ethnic groups, people speak and communicate in different ways. Having a community health worker, not only with lived experience of incarceration, but being of the community is a huge help when it comes to interpreting legalese and medical terms, medication. It goes a long way. Also, health and social service navigation. A lot of people are intimidated reintegrating with a lot of our social service. And so helping them navigate not just the health system, but social service navigation as well. Emotional support and mentorship, health education, and management of chronic conditions, as well as being an advocate for those returning. Here we have TCN evidence-based results. The TCN program reduces emergency room visits for patients, tremendously. The program also is associated with fewer preventable hospitalizations, and the TCN program impacts criminal legal system outcomes, prevents recidivism. We also have some data here that shows on this graph where Santa Clara Valley Medical Center and the TCN program, it shows rates of scheduled primary care appointments referred from the jail or health staff from the jail, 33% of collaboration or engagement. But with a referral from the jail with a community health worker doing in-reach or meeting that person pre-release, they had a 70% rate of engagement. So contact with community health workers with histories of incarceration increases the post-release engagement tremendously. Hiring for health equity, 317 billion in earning potential loss every year by people with a record or criminal record. People of color disproportionately impacted by criminal records. Health systems have excluded people with criminal records from employment. And hiring people with lived experience of incarceration builds health equity and improves health, and it saves money. When I first read that, I was like, what do you mean it saves the state money? And they gave me the statistic that for every dollar the state pays a community health worker, it saves the state $2.55. So this was the overview. Now I'm going to pass it to my colleague, Alicia, and she's going to talk about TCN community health workers being part of a primary care team and working in a clinical setting. Alicia, and please introduce yourself, Alicia.
Okay. Hi, my name is Alicia Ashorn, and I'm a community health worker at La Clinica's transition team. Well, La Clinica North Vallejo. Let me slow down. La Clinica North Vallejo is a part of the La Clinica network. We're community clinics located throughout Solano, Contra Costa, and Alameda counties. And within that system, we have one transitions clinic, which is located in North Vallejo, California. I live and work in North Vallejo. So I was born here, grew up here. So inevitably, I come across clients that I grew up with who are just getting out of prison. I myself have lived experience being incarcerated. And this was the first job that actually I was able to tell my interviewers that I have been to jail and not had to worry about them not giving me the job. So you can go to the next slide.
Okay, sorry.
So this is Dr. Ann, our primary care physician, and this is one of our patients.
Oh, sorry, went too many.
And this is one of our patients. So we get most of our patient referrals from the TCN, the network. We get referrals from them, pre-release referrals, so we know when they're going to get out. We know their contact information. We know what kind of health problems they might have. So we're able to make them an appointment and get in contact with them pretty much right when they get out. We have a couple patients right now who got out on compassionate release. They were never supposed to get out. And so what I do as a community health worker is navigate them through the process of applying for Medi-Cal, with job placement, with housing, just basically anything I can do within the community to connect them with resources, because when they get out, it's a lot. So Dr. Ann, make sure they're healthy. They can call me anytime if they need a refill. I can get a message to Dr. Ann. We just try to make it easier for them because they've got a lot to deal with. So next slide. So we have a team of 4 at the Transitions Clinic. We have 2 community health workers, both with lived experience of incarceration, and Dr. Ann Finkelstein. She's the primary care physician. She's amazing, and our medical assistant. So I guess that's all out of me. Thanks.
Alicia, do you mind explaining what compassionate release is?
So compassionate release, there's 2 examples right now. Compassionate release is when somebody has like stage 4 cancer, or they're not going to survive, so they let them out in order to be with their family and not die in prison. One patient we have now, he had to fight for a compassionate release, who has stage 4 cancer. He's now living with his niece, and Dr. Ann is helping him navigate the services that he needs. But so, yeah, he'll get to die outside instead of in prison.
All right. Thank you, Alicia. So that was working part of a clinical setting. Alicia works directly in the clinic. She's part of the team, a primary care team. She's part of the decision making. They lean on her a lot. She's the eyes and ears of the program in the clinic. The providers really entrust her a lot. She's doing a really great job. Thank you, Alicia. And now we'll talk a little bit about community health workers doing outreach and engagement. So this is a picture of Monya Harris. Again, she fell ill this morning and was not able to participate. So I did want to show her doing outreach out in the community. She also has a program that she created just exclusively for women. So outside of the clinic, she's out in the community where she has these sessions, healing sessions, where she uses these beautiful journals for the ladies, empowering them, also providing resources and tailoring rather, that directly to women's health. She does a great job with that. Here's a picture of them in one of their healing sessions. They cater it, have food. They just did a book bag drive for going back to school. So not only supporting the women when they transition back home, but supporting their families, their children. And Monya does a really good job. This is a program that she drafted and created. TCN helps to support it. And she's based out of Connecticut. She's in New Haven, Connecticut. Here's a picture of their toy drive where they surprised the women who had children with a bunch of toys to give to their children. So very, very moving and encouraging work outside of the clinic outreach. Here in North Carolina, community health workers meet returning citizens in the community at transitional living homes. So Alicia talked about working in the clinic, but we also, our community health workers nationwide also work outside of the clinic doing outreach. The picture here on the left, Straight Talk Support Group Transitional Home for Men, can house up to 20 men at a time. Our community health workers know that there's barriers upon release. You know, you have all these barriers: transportation, housing, food. And so a lot of times you put your health care on the back burner. If you have to decide whether to work, make some money, have a roof over your head, or treat your asthma or treat your hypertension, you're probably going to get that roof over your head first things first. And so we eliminate that with transitional living. And we also assist by meeting them where they are. So our community health workers, myself, Tommy Green is going to talk in a little bit, and community health workers across our nation, across our network, go to these transition homes to intake and meet people where they are, right here in these homes, to sign them up for the program, as well as make appointments for primary care. The program pays for their visit if they don't have insurance, and it also provides vouchers for their medications. A lot of times upon release, you're only released with maybe a 90-day supply of medication if you're lucky at the most. And after that, if you're uninsured, then you go untreating your chronic illnesses. The house on the right is the Freedom House. The same thing. This house is for women, however. Again, our community health workers go to these residents on a weekly basis to make sure that they have the resources they need, but most importantly, to connect them to healthcare. And sometimes we have to meet them where they are with barriers to transportation and things like that. Again, working in the community, here are a couple of pictures working inside of the pharmacy. Lincoln Community Health Center has a pharmacy on the left side. community health worker here is helping someone fill out paperwork because they were indigent, and also wanting to helping them complete paperwork to get their medical records from the prison system, which could take time. And so you want to make sure that they're getting treating their chronic illnesses and getting the right medications. But if we don't have their medical records, which they don't come home with, they're not released with, and a lot of times they don't know how to go about obtaining them. So again, the community health worker meeting these folks right where they are and assisting however necessary. On the right is Ron Sanders. He was the first community health worker in San Francisco for our TCN model, and he's still working there today. But again, explaining what the visit summary is, when the next appointment is, what medications he should be taking, medication adherence, just helping them to understand what's going on. Our TCN team also outreach goes into San Quentin prison, but we write articles. Part of our outreach is we write articles around health information. We provide health information through the San Quentin News, which is a newspaper that circulates throughout the prison in California. And by keeping the health information relevant, changes in Medi-Cal, which is Medicaid and other places, changes in insurance information, where you can connect depending on the county you return to for a community health worker. We keep these articles going in this newspaper that's circulated throughout the prison to help assist and fill in the gap for those that might not return to a county where there's a community health worker or a TCN clinic. Also, we have a hotline. The Transitions Clinic hotline is in California only. But when I tell you about this hotline, I'm sure you will agree we need a hotline in every state there is. Here in North Carolina, we have a recidivism hotline that helps on the outside. But this hotline, TCN hotline in California, folks inside can pick up the phone, jail or prison. All this number won't be charged. And we have a community health worker on the other end to answer that call and answer questions about connecting to healthcare, about your release date, about starting your application for Medi-Cal if you haven't received those benefits or are not connected. All these prerequisite things to help your transition go as smooth as possible. This hotline is great. It's run by Sharon Phoenix. She's our hotline coordinator. And Alicia has recently, she's actually doing her onboarding now to be one of the community health workers to answer this hotline. It's nothing like calling and having someone on the other end that understands what you are experiencing because they've made a transition themselves. That's the uniqueness of TCN community health workers. I'm now going to pass it over to my colleague, Tommy Green. He's going to talk a little bit about InReach. Tommy does a little bit of everything. I'm going to allow him to introduce himself, but he's going to talk about InReach and going inside of the carceral system, amongst a few other things. Tommy.
Thank you, sir, for that warm introduction. Can y'all hear me okay? Everything's good? Okay, cool. So I'm Tommy Green. I'm the lead community health worker for the NC FIT program. I'm also the program manager for our Orange County FIT program. Been doing this for quite a while. I think we started in 2000 and, why am I drawing a blank? 18. Yeah, I started with FIT in 2018. You can go to the next slide. Just to give you a little bit about NC FIT. Right now so my apologies for this slide being a little bit out of date. We're actually in 7 different counties right now. The ones that are missing, maybe they got clipped off, but my county's not up there, which is Orange. So Mecklenburg, Wade, Guilford, Forsyth, and Hanover. Sorry, I'm drawing a blank, y'all. I think I'm missing one. Greensboro, Guilford. Anyways, so the FIT program has a few different programs inside of the program, right? We have FIT Wellness, which is a program that connects people with SMI to not only the community health worker and healthcare, but we also like kind of focus on their mental health care. We connect them to a psychiatrist while they're in. We follow them out the door. We make sure they get connected to mental health services following their incarceration, and also keep them connected to their psychiatrist, and provide all the wraparound services that NC Fit already provides. I'm sorry, y'all, my phone will want to ring off the hook when I start. Also, the other wraparound services that FIT provides, where on one leg we guarantee the healthcare services. We've been able to secure enough funding to cover their co-pays and up to $150 worth of their prescription costs. And then on the other end, we work on what we call a comprehensive reentry plan, which focuses on the other boundaries that they may face post-incarceration, access to housing, employment, social security needs, things of that such. Another one of our programs is Fit Recovery. Fit Recovery focuses on people with SUD and OUD issues. And what we do with that program, we identify people that have SUD issues, substance use disorder. And what we do is we get them on MATs while they're inside if they have not already been put on MATs. And then what we do, similar to the wellness program, we track them out the door, and then we make sure that they stay connected to their substance use disorder treatment programs, and/or connect them to other organizations in the community that could help them with their substance use disorder. For all the counties that they actually have a FIT county that actually have a FIT program, we get them in the FIT program. And then, of course, they take advantage of the perks that I just listed. And then we have one other program, a statewide program called the NC TAC program. It's technical assistance, where FIT is part of a 3-part collaboration with NC Harm Reduction and Duke Collaborative to offer technical assistance to all organizations in the state that have reentry services, diversion programs, and harm reduction programs. And so, speaking of InReach, as you can see, a lot of our programs are geared towards kind of connecting with the clients before they're released. Even with the regular NC Fit program, we do a lot of InReach in all our local prisons. Actually, when COVID hit, we were kind of stifled off from that. We're really now just getting back into the groove of going back inside of the prison. And we're a very intricate part of what they call their RSTEP program. At least in my area, in Orange County, they have what they call an RSTEP program, which it's like a program that's designed for people that are short, only have like a few months, maybe a year, and where different organizations like the FIT program come in and sit down with the guys and talk about our programs. Whoever is qualified, we enroll them. And again, it's like we give them a leg up. When you do InReach, you give them a leg up because you give everybody a chance to kind of hit the ground running. Let's go ahead and establish some things like maybe even putting in like to get their Medicaid turned back on, making family connections where needed. A lot of times this population of people, tend to burn bridges. So it helps to have an advocate in that regard as well. And so sometimes we can identify those issues while we're inside. I can't even mention how many times, I've met with a guy while inside and, they were having troubles getting in touch with their family while they're inside. And then they use me as kind of like a conduit to send a message or to let their people know that they've been trying to get in touch with them or they're close to coming home, try to get their home plans established. Because I'm telling you, that's like the worst thing in the world to try to get ready to get close to getting out their door and not really knowing where you're going to go. You can go to the next slide, Dorel. So one of the biggest, I like that picture. You caught me with my mouth open too. But anyway, one of the biggest weapons that I would say that we have in our arsenal is our ability to advocate for our clients, right? A lot of times we like to look at the situation as we're the voice for the voiceless, So advocating is like one of the biggest duties and responsibilities, I would say, within this organization and just doing this work in general. Because again, we open a lot of doors that traditionally these clients wouldn't be able to open without someone on the outside vouching for them. One of the best and most unique things about the program is not only all the community health workers are just involved, but we're connected to a prominent organization like UNC. So that gives us that gives us the autonomy, for lack of a better way of saying that, to be able to say, hey, you know, this person is participating in this UNC program. They're doing good. They're doing everything they need to do. And a lot of times, you know, it makes a difference. Whether I've actually had the luxury of saving people from probation violations, saving people from just doing time in general. Because a lot of times, you know, a judge will accept, especially when it's a drug charge, and you can clearly see that this client committed a crime because of their addiction. A lot of times, a judge will gladly, in our area, give out probation as opposed to sentencing if they know that that client is connected to the FIT program. You can go to the next one, Dorel. Again, I cannot highlight enough the relationships that we have with our clients. For us, by nothing for us without us is a model that was coined by TCN, and I really believe in it because I always use the example for like our academics. You know, when you go off to college, you're in a strange land, and you meet someone that's from your hometown, right? So when you meet that person from your hometown, you those walls start to come down. You got a familiar face. You got someone that can vouch and say, "Hey, this is where the chow hall is. This is where the student union is. This is a great class, but this professor's a jerk. You might want to take it over here, so on and so forth." And so it's the same thing when it comes to the work that we do. You know, you're dealing with a population of people that has been stigmatized their whole time. It is coming from probably the worst situation they've ever been in. And again, coming out doesn't really have not really have the support that they truly need. Because again, you can have all the family support in the world, but if that family support has no history of incarceration, they can't really relate to what you're going through. They really can't point you in certain directions, or they really can't understand simple things like when you're having a bad day, or when you're, you know, kind of scared of change, because that's the thing too. You got guys coming home from a long. I myself did almost 12 years, and I'm a pretty tech savvy guy. But when I came home, it was things that were really throwing me for a loop. And you know, thank God I had a strong support system, a strong support cast. But looking back in retrospect, I see that, you know, the benefit of someone with that similar lived experience, and how I could have took to some of the things that I was trying to learn from my family a little bit better. I felt alone a lot of times, and literally be in a house full of people and still feel alone because nobody there could really understand where I've been, what I'm going through, my fears now, and so on and so forth. So again, the relationships of having a community health worker that is formerly incarcerated and dealing with other people that are formerly incarcerated, we bridge that gap like no other. In this picture, you can see that's me, Dr. Ashkin, our provider and actual director of the program in the middle, and one of our clients. And it's funny that we actually use this picture in some of our promotional stuff, because that particular client was one of those people that were kind of leery about dealing with not being funny, but dealing with an older white guy that he just could not relate to, you know. So with that being said, me literally sitting in on some of his in some of his appointments, me and him having some real heart-to-heart conversations outside of his appointments about the program, about the compassion that our director felt to even start this program. And next thing you know, his defense is dropped. Now I don't have to be in the room with him to get adequate care. You know, he's totally comfortable with Dr. Ashkins now, and it's because I was the person that vouched for Dr. Ashkins. You can go on through. Here, I know y'all heard me mention the Fit Wellness program, and so Fit Wellness, even though we're in 7 counties, Fit Wellness was only available in Wade County, and so this $5 million that we received from DHHS actually affords us the luxury of expanding the Fit Wellness program to Durham County and Orange County, which Orange County is my county, so I'm really excited about that. And again, we're kind of limited on time, but if you get a chance, please look up the Fit Wellness program. That program is really phenomenal. I think we're doing some great work in that regard. I'm in touch with the community health workers that run that program a lot, and the stories that they're telling me about what they're doing and the goals that they're accomplishing with their clients is amazing. So definitely good thing that we're able to expand that program, and hopefully eventually we'll be able to expand it to all our counties. And I think the last one is it. All right.
Yeah, that's back to me. Thank you, Tommy.
Yes, sir.
Again, as you can see, just a wealth of information. We do have limited time. We have about 10 minutes left. I want to save time for Q&A. A few people are asking questions now, and if you can use the chat feature, but you also can raise your hand, and hopefully our tech support will allow you the opportunity to come on mic and say what it is you want to say and ask questions. The work that they're doing with that fit wellness, I just want to give this backstory real quick. I was working here in North Carolina as well, so I work remotely with TCN, and I am in North Carolina with Tommy. And we had a patient come home with a mental illness, very severe mental illness with psychotic features, and he had a medication that was so rare that no provider would touch it when he came home. But I was able to go through our provider, Dr. Ashkin, that was on the picture and Tommy keeps referring to, and he was able to connect with the psychiatrist from Central Prison, the prison where he was released from. He was under that physician's care, psychiatrist's care. And because of that FIT program, and what Tommy was talking about, being connected to these entities like a Duke University, a Yale, University of San Francisco Community College, like all of these programs that these TCN models are connected with, allows us to have resources to reach back and actually save lives. So this gentleman was able to get that medication. It was so rare, and his white blood cells would drop really low. So I had to also take him to have his blood checked every week. But not only with this medication, and he cried, and I cried, because without this medication, not only did we save his life, but we potentially saved the lives of those around him, because with the psychotic features, he would become very violent. And we were only able to do that because of this program. So our community health workers, do life-saving work every day. All of the community health workers in NACHWA, and that's why I'm so excited about NACHWA and this Unity Conference, to see all the different ways that people do community health work. This workforce is growing, and we're at the table to make sure that we are heard too, those with lived experience of incarceration as community health workers. So as this workforce continues to grow and we continue to hire more people, I personally do training of community health workers with the TCN model. So if you're working, we're connected with St. Louis now. I saw somebody in the chat talking about that. Shout out to St. Louis. Hope that we can get this model there, and I can train community health workers to do this work. In summary of what we just talked about, the Transitions Clinic Network addresses the unique healthcare and social service needs of individuals returning from incarceration by hiring, supporting, and training community health workers with lived experience of incarceration. The TCN model improves health outcomes by integrating these CHWs into primary care teams to foster trust and ensure effective communication between patients, healthcare providers, and community partners. We hope to have provided insights into how this model enhances healthcare and promotes community well-being. TCN CHWs support vulnerable patients in a variety of settings, including clinics, jails, prisons, and the community, to essential care. Future efforts will focus on expanding this initiative model, hopefully to St. Louis next, shout out to St. Louis again, and leveraging new policies in Medicaid that impact healthcare and reentry processes. So we're breaking down barriers, right? And we are promoting healthcare, and we're saying it's okay to ask for help. Your mental health, your substance use disorder, as well as your chronic illnesses, you have somebody that you can relate to that's also had to reintegrate back to society. So we're modeling every day. It's phenomenal work. I always say I would do it for free, but it's always a plus to get paid for it, right? So we want to continue to build this workforce. Here's a picture of us at our national convening. So every year we have a national convening where transitions clinic all over. These are just the community health workers. Look at those beautiful faces. These people doing phenomenal work. They have so many testimonies and so many stories, you know, where folks won't even see the provider if it wasn't for their voice, if it wasn't for them advocating, if it wasn't for them making that appointment, that emergency appointment, getting that emergency medication, you know, going above and beyond. Community health workers are the greatest, and these are our network community health workers. This is a picture with the providers included. We have a great time in Los Angeles every year. We have a convening coming up in January of 2025. It's amazing that we're almost in 2025. But again, looking forward to networking with these great folks and seeing them again. We also have fireside chats where I facilitate those. Tommy co-hosts sometimes and comes in to help. And the purpose in this fireside chat is for us to discuss problematic things in the workforce. So without our supervisors present, without our program managers present, it's time for us to come in. So it's structured, but it's very informal, where we come in and we talk and iron sharpens iron. We're able to support one another. Somebody comes in and they're having a bad day, a lot of pressure. Everybody will rally around that person, community health workers, and just show them love and support them in a major way. I always promote self-care. Again, this work can burn you out. You can experience compassion fatigue. And so I like to promote wellness in these fireside chats as well. We do a self-care check-in. Make sure you're doing the things to keep yourself well, because if you're not well, you can't possibly help anyone else get well, is our motto. We're going to pause for questions and answers now. We got about, I guess this session lasts for another 10 minutes or so. And before we do the questions and answers, I do want to ask Tommy and Alicia to share a highlight of being a community health worker with TCN, as well as maybe a challenge, something that's been a challenge. And I'll start with you, Alicia. Are you still there?
I'm here.
Share what a highlight is, as well as what maybe a challenge has been for you.
The highlight is easy. So every year we do a fundraiser where people from the community come. We usually have some kind of food involved, and we raise money to keep a fund for, it's the P40 fund technical. But anyway, we have this money that we can do things for our patients. And we had this one patient, actually, if you go back to the slide, Dorel, he's the one in the photo with Dr. Ann. He was going through some things, and he recently lost, something happened. He lost his Social Security, he lost his food stamps, he lost everything for a while. So I was able to go, and he had been depressed, and he said he hadn't had a, anyway, I went to Costco and I bought him a bunch of food and went to his house, took him out and got him a haircut, because in his depression, he was letting everything grow. And we went to the barber shop, and he walked out of that barber shop like a whole new person. And that was just one of the pinch myself moments I have doing this job. When sometimes we have clients that get a new job and they need work boots, and we're able to buy them work boots. Or one client, we were able to pay his late car registration because he got a job and his tags were expired. That's him right there. So yeah, he didn't have that. He looked like that when we walked out of the barber shop, but when I picked him up, his beard was all over the place. But I don't really have any challenges so far. I've been doing this for a little over a year, and I just love it. It's the best job ever. So
We love you too, Alicia. Tommy, can you speak to maybe a highlight of doing this work, and if there have been any challenges that you want to speak about?
Yeah, so a highlight to this work is definitely our convening in LA every year. It's always fun to come out on the West Coast. But seriously, a work highlight. I mean, to be honest with you, to me, man, it's a highlight every time I really help a person overcome a major challenge. And the biggest challenges we face in this area is housing, right? So anytime I can get somebody, like for example, I just between me and collaborating with our local reentry council down here, we had a guy. He's on this sex offender registry. He has he has a major heart condition, diabetic, and has it's one other thing. He had three. Has something going on with his liver right now that we're still trying to figure out. And so, long story short, this guy came home. And, you know, when you're on the registry, you got to have a place, you got to have an address, you got to check in with the sheriff's office, so on and so forth. And this guy had absolutely nowhere to go. Um, Tiffany, which is the local reentry council case manager, she had exhausted her resources. I had exhausted our FIT funding for hotel stay for him. We put him up in a hotel for a couple of weeks. And when those 2 weeks ran out, you know, he spent 2 days actually sleeping in his car. And of course, with those type of conditions, that's the worst thing that could happen, right? And so on day 3, is when we had this hurricane scare not too long ago, right? Or tropical storm, whatever it was. And so, you know, in North Carolina, when we get any type of hurricane, tropical storms, tornado, anything, North Carolina shuts down, you know. And it's always a crap shot. You don't know if it's going to really hit and be as bad as they're predicting, or it's just going to be a light blow up. So now we're in a position where we got to get this guy off the streets. He's living in his car. Might be a hurricane or whatever coming. So it's like it's almost life or death for him. So in the fourth hour, fourth quarter, however they say it, right? We found him a place. We found him a transition home that would accept sex offenders. We did everything we were supposed to do to get him in. And the local reentry council actually had the case manager there actually found a little bit of funding to be able to cover his first month at the transition house. And so when things like that happen, to me, those are always the best highlight stories, because literally I look at those situations as not only did we keep a man from sleeping in the streets, but we may have saved that man's life. Because who knows if he'd have made it through the night in that car. He was already bad off from the first couple of nights, but night 3 probably would have ended him. Who knows? So that's kind of like a highlight. And the things the most challenging, housing, of course, in our area is the most challenging, but just to speak as far as like on an overall basis and just like, you know, talking for my coworkers included, I think one of the most challenging things is the empathy that you feel for your clients. You know, it's hard to deal with someone that you see a lot of yourself in and then go home and have to decompress from that, for lack of a better way of saying it, especially if it's someone that you can really relate to. And for that particular day, maybe you didn't accomplish something or didn't quite get something that they needed. Then you got the luxury of going home, but you have to worry about that client that might not have a home to go to. That might be the ball that you dropped, or not even necessarily. I wouldn't even say the ball that you dropped, because sometimes it's just not there. The opportunity or the opportunity for housing is just not there. And so a lot of times I see our community health workers take things like that really hard. You know, everything that happens to them kind of happens to us. So I think, yeah, that's the biggest challenge, you know, being able to accept sometimes maybe you can't get that situation done, or maybe that situation is just a little bit too much for you or whatever or whatnot. And also too, not taking those failures when you do everything you can and the client still recidivizes or the client still relapses. You know, things like that, I take on the chin sometimes, like, dang, man, I hate it because I can do the most for that client and they still turn around and still use and still, you know, do what they feel like they have to do and end up going back. So those tough breaks, I think, is the biggest challenge in this area, hands down.
Thank you, Tommy, for sharing that. I concur. I see people in the chat like, yes, like they can feel it. And I think that's not just with us with this model. Like, that's community health work across the board. Everybody doing this work, you know, survivor's remorse, distress remorse, call it what you want. Like we're in this because we want to help people. But a lot of times, you know, you do all you can do. And that's part of the training. So before we open up for questions, I do want to save time for that. Part of what we do with our training too is mentorship, right? And that's the importance of that fireside chat, is being able to express that, being able to get support while maintaining professional boundaries, right? Because we have to maintain our professional boundaries. We have to not get too involved in too committed. It's hard. It's hard. Sometimes it really gets hard. I put that picture back up of these smiling faces. I love this photo, and hope we continue to make these photos. You know, so for me, one of the challenges, and I'll start with the challenge, is maintaining the workforce. And that's why I advocate for NACHWA, that I'm joining that policy working group. We got to sustain this workforce, right? They could never pay us what we're worth. We know that. They can never. It's not a dollar they could give us for what we're worth, right? But we got to find ways to sustain this workforce. The challenge for me is I keep losing good community health workers. Every time we network and I find somebody that's solid in a position, but I can't blame them for moving on to greener pastures. But this is what they were called to do. Like, this is why they're there. They do this so well. And so that's been the disappointing thing for me. It's just finding a way across the nation to support one another, joining NACHWA. You know, I promote it all the time, joining that CHW policy working group. You know, we have to be our voice. We are the union. We have to be our union and be a voice, one body to support this workforce, because we want to sustain, we want to keep these positions. We want to be able to be advanced. Tommy's been blessed. He didn't talk about it, but he was promoted to program manager. That's great. But some situations where we work, if you don't have certain degrees, then that's not available for you. And so, yeah, I don't want to continue to lose good community health workers to having to move on because of livable wages. Everything's going up, our pay should go up. So that's been the challenge for me. And the highlight, of course, is training community health workers. I have 12 years experience of training peer recovery coaches and peer recovery specialists here in North Carolina. And now, you know, training community health workers is the highlight for me, because I get to not only train on best practices and core competencies, but I also get to meet and network with great people across the country. So a dream come true for me, for sure. I'm going to put my contact up for a second, and then I'm going to stop sharing. Some people are asked questions. Please feel free to email me. I can connect you to Tommy. I can connect you to Alicia, and even the women's health. Monya's in New Haven, Connecticut, and they're doing a lot. Excuse me, they're at Yale School of Medicine. If you want to reach out to any of the panelists or myself, any of the presenters or myself, just and you can visit our website at transitionsclinic.org, or you can email me at dorel.clayton@ucsf.edu. I appreciate everybody for allowing us the opportunity to present, and I'm going to stop sharing now and open up for any questions. If you use the raise hand feature, I think our tech will allow you to come off mic and ask your question.
Hello. My name is Treva Smith. I'm here in Topeka, Kansas. I'm also on the board here at Nashville. But my question is, are you training any or know of any folks who are training residents or training before they leave the system? I've had the opportunity to do some of that training here at Topeka Correctional Facility, and I would like to talk to anyone else who may be experiencing that and see how we can partner and just learn one from another.
Absolutely. Thank you for your question, Treva, and shout out to Kansas. That's something that we're working on now. I think working in silos never helps our cause. And so I think maybe a collaboration you, I, whoever, because we really do need to train this workforce. We're talking about reentry. And what I realized is it's really hard whenever a community health worker leaves, it's really hard to fill these positions. To have someone that, you know, can do their documentation, professionalism, and still have the lived experience of incarceration is kind of uniqueness. And so what we've started to do is to look at some of these reentry programs that are on the inside. They've started teaching peer support on the inside, but how does that translate to the community and professionalism? So what we're trying to do now is create a pipeline where we can start training on the inside, at least some of the core competencies, and getting people trained up, ready to do this work. Because who better to help somebody re-enter than somebody that's re-entered themselves? So I appreciate your efforts in the work you're already doing. And please take my email and let's have a further, more robust conversation about it. Okay, I see your email. Anybody have any questions? Use their raise hand and our tech will allow you to speak if you have any questions. Marco.
Yeah, how's it going? Great work. Excited to hear this work. My co-facilitator and I were just talking about um the importance of this and trying to find a way to add incarceration and recidivism and things of that nature into our CHW training modules. Do you all have any material or anything that you all are already using to like train community health workers to deal with the returning citizen population or maybe the reentry population before they even leave the jail or whatever?
That's a great question, Marco. So our model, our TCN model, and me training community health workers with lived experience, we do have a curriculum that we use. However, outside of TCN, and I'm not trying to promote myself, I'm just saying I would love to collaborate you on building something like that. I actually have a reentry curriculum. It's for peer support, but it's catered to reentry and supporting those that are returning. So if you take my email as well, I would love to collaborate with you on building something like that. We have a bunch of core competencies already that you could probably take from that I would share. However, the one that we use for our transitions clinic network is just for our network. But I would love to have that conversation with you and help build something like that. We truly need it. I think we got a couple minutes. Anybody have any more questions? Just put your raise hand on and our tech will let you in to speak or give you permission to speak. Yeah, Marco, the fist bump. Boom, we got it. We got to continue to network and build. That's how we can get these things done. You know, we got to do it together. That's why I love Natchwa again. And I appreciate this Unity conference and the opportunity for us to present. Anybody have any other questions? Okay, for any other reentry programs, yeah. Let me get that email up out of there before it's gone. Definitely want to collaborate with any reentry programs. We're looking forward. I was privileged to be part of a few of the meetings in St. Louis about getting this model there. Very enthused. I feel like it's just a matter of time. It's going to happen. I can't wait to train community health workers in St. Louis and get involved. Yeah, I'm excited as well. That's great. And we should have these programs. There are prisons everywhere. There are people returning everywhere, which means they have chronic illnesses and they need health care everywhere, right? So we should be trying to have these meetings, I mean, these clinics set up using this model. Oh, thank you, Tommy. Using this model and hire as many and train as many community health workers as we can. Last year's Unity Conference, tremendous, tremendous. That's great. That's great. I'm so excited to even be presenting at this year's Unity Conference and to talk about TCN and the work that we do. It's very unique, but it's community health work still, and we got to continue to build this workforce. I'm a huge advocate for building this workforce. I want to thank all of y'all for joining this session. And again, my contact information. Maybe I should have put it back. Let's see. Let me pop it back up before they kick us out. Don't know how long the session lasts exactly, but yeah, just shoot me an email for networking purposes. Let's sharpen some iron. Let's talk. Let's have conversations. Again, Tommy had to leave. Thank you again, Alicia. Alicia's doing phenomenal work where she is. And yeah, thank everybody for coming in. Please take my
Thanks
email.
for asking me, Dorel.
Oh, no problem.
This was very cool.
Yeah, I appreciate you very much. Doing phenomenal work. Yeah, so please feel free to email me. Oh, we have some. Okay, well in that case, let's continue to talk then. I'm sorry. I thought it was 5:15. We got 10 more, about 7 or 8 more minutes. So let me say that another thing is in your state, do you have and you can just put it in the chat. You don't have to come on mic. You can put it in the chat. Do you have a community health worker curriculum? Because that's another thing that I'm trying to work on in different places. We have one here in North Carolina, a certification program. I'm sorry, not a curriculum, a certification program. A lot of states don't have certification programs. Okay, Tracy said yes. Yeah, a lot of okay, in VA for sure. I'm right here at VA, several in Illinois. Great, great. Statewide certification, great, great. And you know, it's amazing that California is working on one. California is one of the leaders when it comes to employing and volunteers of community health workers, and still working on a statewide certification. Some people afford, some people are not, but I advocate for it to have these credentials. Great in Missouri, great, 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 Tree, but that's great. I have a curriculum certification, but I teach still. Cool. Yeah, you got to talk about TCN. Yeah. Bertie County. Okay. Okay. All right. Yeah. And Bertie, we do have a curriculum in the state, though, here in North Carolina. Honey, a lot of folks with Nashua know Honey. Honey is our chairman here in North Carolina. So yeah, we got to continue again, come out of these silos, and we got to work together. Annual brand masses and health conference. Okay, well, hey, Veronica, let them know about us. Let them know about TCN. Bring this information. I've presented at a lot of different conferences, but I'm always looking to spread the word about, again, community health workers are doing life-saving work, life-changing work, and health and the lack of health care is a public health issue, right? The lack of health care is a public health issue. Everyone should be entitled to health care as they see, and so we have to continue to push for that. Dorel Fox, we just having a conversation. Me and him share the same name. It's just spelled different. I've been looking forward to meeting Dorel, in person, or at least having a conversation. So I'm glad you're here, sir. Again, a few minutes left. Anybody have any questions for me about TCN or about the work? I apologize. I ended a little early. For some reason, I had 5:15 in my head. It looks like we have 5 more minutes. If anybody has any questions, if you use your raise hand feature, our tech person will allow you the opportunity to speak. Or if anybody has a comment or anything they would like to share, that's fine as well. Absolutely. Yes. There, I see you, Sarita. Veronica, yes, we have a ton of women involved with TCN. In fact, we have more women CHWs than we do men. Sarita, can you ask your question or make your statement?
Yes, it is just a comment. I'm happy that my co-facilitator and teammate Marco asked a question, but I am from a rural county in North Carolina, so just being a part of this presentation gives me hope where the hope was really flickering, right? With high incarceration rates and nothing really to come home to. And so this is just that hope, right? That look at this work and in North Carolina. So I'm just excited to have conversations about this, about how we move this all across the nation, and of course I'm particular to my rural areas, so just thank you for the work that you do.
Absolutely. And yeah, Bertie County, there's actually a 1,000-man unit prison in Bertie County. So why not have reentry services there, right?
Right, that's
That's
right.
right.
No, it's just a
Yeah.
federal prison that you either work there or you're incarcerated there.
Absolutely. Right. And that's the uniqueness of it. I'm glad you're here. We do that technical assistance that Tommy was. I don't know if you heard the whole presentation, but that technical assistance we do. We went to Western North Carolina and Eastern North Carolina and different places with that technical assistance. We would love to do some technical assistance in Bertie County. So make sure you take my email, stay in touch with me,
Oh,
and
I
we can
have
bring
it.
some of these resources to Bertie County. And if they're not there, like that's what we do, right? We can create these things and make sure that they're there because folks need these services. National CHW Alliance, Marco has that in there. Yes, absolutely, Veronica, and that's what I said, right? There's no reason. So in North Carolina, our TCN model is called NC Fit, formerly incarcerated transitions here in North Carolina. And we have 100 counties. We need 100 fit programs, don't you think? It should be a program in every county. We had mass incarceration, and so now we have to have mass healing. We got to figure out how to get these programs. Every single county, it should be one. In every state should have a transitions clinic where folks can get health care, get resources. Every person, every state should have reentry councils. We have to pay attention to this. This is the backside of mass incarceration, right? So we definitely need mass healing, absolutely. And community health workers will be the forefront of that. We're the healers, right? But healers need to be healed too. So before I leave, looks like I have a minute or so. I want to promote self-care as I always do. Make sure that you're taking care of yourself. Burnout. I know Marco second that compassion fatigue is real. Burnout and compassion fatigue is real. So on my way out of the door, I want to promote self-care, tell you to be well, do the things that keep you well, and take time for that. We schedule everything else. When I tell you burnout is real, it's real. And if you haven't experienced it and you're doing community health work, brace yourself, but start being proactive about your own self-care and your own wellness, because hurt people, but healed people heal people, right? So we want to continue to do the work as community health workers, and continue to heal one another with our work and our passion and the things that we do. Thank y'all for your time. Again, thank you for joining this. Thank you for listening to our presentation. And I said my email again is Dorel, Dorel .Clayton @ucsf.edu. So please email me questions, concerns, even if it's the network. Join our fireside chat. It's for community health workers. So join our chat. Let's continue to do this work. Salute to everybody at the Unity Conference 2024.